Hello, my name is Dr. Lewis Hoffman. This presentation is for the International Society for Ethical Psychology and Psychiatry conference held in Portland 2016. I'm very pleased to be an invited speaker for this conference and disappointed that I'm not going to be able to make the actual conference. I had some complications as I was preparing to leave for the airport and missed my flight and have been unable to secure a flight to get there in time for my presentation. I'd really look forward to being a part of the conference, attending other presentations, and being able to be more interactive in this presentation. Video lectures are not quite the same as being able to interact and engage with people at the presentation, and so I'm really disappointed for losing out on that opportunity. I do want to thank the organizers of the conference, first for inviting me to be a part of the conference, but also for everything they've done with the preparations for the conference and in helping me prepare for this presentation. In particular, I want to thank Dr. Chuck Ruby, who has been wonderful helping me with the preparations for the conference and also in working with me when I missed my flight, leading to my inability to be able to make it there to be with all of you. I hope that this lecture in some ways will help to fill the gap for me not being able to be there, but do recognize that it is not quite the same. In this presentation, I'm going to try to cover a brief history of outcome studies leading to evidence-based practice, then reflect a little bit on some considerations about evidence-based practice, talk about multiculturalism and then existential-humanistic therapy and evidence-based practice, and then reconsidering the evidence. What's at the heart of this presentation that I hope is evident throughout is looking at this idea of evidence in an ethical lens and understanding that there are both practical and ethical implications to how we define and understand the word evidence. So as we get into this and we look at a brief history of the outcome studies leading up to evidence-based practice, it often is assumed when I have talked to other professionals that the outcome studies started rather recently in the 90s with the push towards the empirically validated treatments and empirically supported treatments. But I don't think this is accurate or fair. It dismisses some of the history of psychology. In the early psychoanalytic thought, there certainly were ways of looking at outcome, but it was in a little bit of a different lens. They did it largely through informal case studies, not the formal case studies as a research method that we see sometimes today, but more informal case studies and case presentations. But these were an attempt to look very closely at the outcomes of therapy and how the activities of therapy influence those outcomes. And then there's Carl Rogers, who took a very intensive approach to outcome studies. And Carl Rogers is neglected for this, but when you look at what Carl Rogers did, they were very intensive, looking back through tapes, looking at them moment by moment, watching how clients responded to different types of interventions. He did this as a research group. He also sent these tapes out to other experts in the field from various different theoretical orientations to review and provide feedback. This was a very intensive way of looking at outcome studies. So it has been something since the very foundation of psychology that we've always looked at and tried to examine what is working and what is not, and I think this is a good thing. Now, more recently, we are familiar with three stages that you still hear some of these, you still hear this language around some. You don't hear the first, empirically validated treatments as often, but I still do hear this come up at times with people. This was one of the first movements, but there was some controversy over the word validated, particularly around it suggesting proven. And so there was a shift to the empirically supported treatments, the ESTs. And these were very influential for quite some time. And it was during this time where I first started to get interested in this to some degree. With the empirically supported treatments, there's a strong privileging of randomized clinical trials. That was the gold standard, as we often hear for looking at outcomes. And towards the end of the period where the ESTs were the dominant paradigm, there was even beginning to be a push to add the ESTs to the DSM and make it an ethical mandate to use only ESTs. And this particularly is where I started to get interested. As an early career existential therapist at this time, was talking with someone who told me that in the light of the ESTs, if I were willing to work with a client with basically any DSM diagnosis from an existential perspective, he argued that I should lose my license and be disciplined by the licensing board just for practicing that because I was not using an empirically supported treatment. This really prompted me recognizing some of the importance of this, to be aware of the empirically supported treatments. Now, as the empirically supported treatments moved along, they did become slightly more inclusive, but still were pretty rigid. And the concerns about the empirically supported treatments grew and grew, and there were a number of different responses to those that had some influence but never really became a dominant paradigm. So the switch in the dominant paradigm really came to evidence-based practice, and this occurred in that period from 2004 to 2006 was really that transition to this being the dominant paradigm in the field of psychology. When we look at the changes that are part of evidence-based practice, I think we can see some very interesting things. The ESTs focus very narrowly on research, narrowly defined research, I should say, particularly those randomized clinical trials. Evidence-based practice shifted that to focusing on three things. Research, which was broadly defined. That's a big difference, broadly defined. Competency or expertise, and then individual and cultural differences. Now, the language I use there is slightly different than was in the original APA Task Force on Evidence-Based Practice report, but it gets at those categories, and I use those because we're going to lead into some of that language that I think is important in a little bit here. But I think it's really important to emphasize that factor that within the research there was moving away from privileging of the randomized clinical trials. Now, after the article that came out that was really introducing evidence-based practice as the dominant paradigm, Wampold, Goodhart, and Levant, who were very much a part of that process, warned that evidence-based practice would regress to something similar to the empirically supported treatment if we were not intentional to keep the understanding broad and inclusive. And history has shown that they were right. This has happened to a large degree. I think it's important for us to consider a bit why this is. Now, when Wampold, Goodhart, and Levant were responding to this original article, one of the things that they said that is important is evidence is not an unambiguous term and is usually undefined, but the term exists in a context and has a particular meaning. Evidence is not data, nor it is truth. Evidence can be thought of as inferences that flow from the data. I think this is a very important quote because it puts evidence in context. And what we're starting to see in the field again is that people are misunderstanding evidence as research evidence. They're misunderstanding evidence as truth. And this is where we start having some, I think, important ethical implications in the misuse and misunderstanding of the term evidence, both in the context of evidence-based practice in psychology and also in other contexts. Now, those that were in favor of a narrower or a narrowing understanding of evidence-based practice, they were pretty quick to begin publishing articles and bringing new, narrower definitions to evidence-based practice. And this is what has, in large part, proven Wampold, Goodhart, and Levant correct in their warning. The motivation to this at times to be political and power-based, more than rooted in the concern for consumers of psychotherapy. And the battle over which approach is best is more about the therapist and the client too often. I don't want to overgeneralize this and say that this is true of everyone. I think there are certainly many people that have very good intentions for arguing for a particular approach to evaluating the effectiveness of therapy. But often I think psychologists, and we're supposed to be aware, are sometimes unaware of our motivations around this, that there seems to be a lot of motivation to secure one's own position in the field, to secure one's financial security, to secure one's position as an expert, to secure one's position as a good therapist. All of these things can come into play around this at times and are something that are of great concern. And again, I think have some significant ethical implications here. Those that are concerned about evidence-based practice tended to focus on critiquing evidence-based practice instead of advocating for a broad, inclusive understanding. And I think this was also a big failure. Is a number of the critiques that I heard of evidence-based practice when we started to move into this period were that they were they didn't understand the evidence-based practice and were really critiquing the empirically supported treatments and confusing them with the evidence-based practice in psychology. So this became a failure too, that set things up for that narrower understanding of evidence-based practice. So as we consider what evidence-based practice in psychology is, there are three pillars of it, as mentioned before, but let me talk a little bit more in depth about these. First is research. The original report advocated for a broad understanding of research that included qualitative and quantitative research. Did not privilege the randomized clinical trials. Broad understanding of research. It allowed for research to be used that was most appropriate for the therapy modality to be used. Now, when we talk about doing research, and I supervise a lot of dissertations, and so conversations that I have with students quite often is, what is the most appropriate methodology for your particular question? Now, what had happened a lot in the empirically supported treatments is that type of question got lost because we chose the methodology before we fashioned the question and took in the contextual factors into account. So that creates a problem. With evidence-based practice, there's a lot more flexibility to do it like we teach students to do with their dissertations, to formulate your question, make sure it's a good question, and then find the methodology that's going to be the most appropriate. And for some therapies, there may be different methodologies that are going to be more appropriate to evaluate the effectiveness of that approach to therapy. It also allows for research to be considered beyond strictly outcome studies of a therapy. So we can look at aspects of therapy that are important, looking at, does empathy have an impact? Do other factors such as meaning have an impact? So we can look at research in a much broader context. So research here really has been expanded to a way that is much more usable a much more inclusive understanding of what evidence is in terms of research. Now, next is the clinical expertise and competency. One of the things that's interesting with this is that a lot of this is consistent with the common factors research that suggests that there are different common factors across the different therapy modalities that accounts for most of the change in therapy. In a lot of this research, of course, it's shown that client factors, they're the number one factor in determining whether therapy is going to be effective or not in most instances. After that, it is therapy relationship factors that generally come in there. And there's different language around that and different conceptualizations. But these common factors then fit very well with the competencies, and we'll talk about some of those in more depth in a little bit here. These also are consistent with what has been advocated by certain approaches to therapy for some time. For example, humanistic and existential therapies have long advocated for a way of understanding therapy that's rooted in competencies. Now, they've not used that language of competencies. They've used stances, approaches, different languages that maybe is a little more ambiguous than competency, but it aligns, I think, fairly well in many ways with this idea of competency, though there are, I think, some differences there too. And allowed for these competencies, evidence-based practice allowed for these competencies to be adapted to the approach. So for example, it does talk about there needs to be some way of conceptualizing the problem, but it doesn't need to be a DSM diagnosis or an ICD-based diagnosis. Rather, it should be a plausible explanation of the problem agreed upon by the therapist and client. Now, most therapies do this. Most good therapists across the orientations do this. This is one of the things talked about in the common factors. And it makes sense that clients, if they can have some understanding about the problem, that is going to help them to be able to work through and heal. If therapists have some understanding of the problem, it doesn't need to be in a DSM or ICD language, but it needs to be in some language that the client and therapist can agree upon and work with. Something that can be used for that communication. Individual and cultural differences. Where the empirically supported treatments required a manualized approach, which really limited things a lot. Evidence-based practice emphasized the importance of being able to adapt to the particular client needs based on individual and cultural differences. Now, I was a little disappointed with the original language used by the task force here to focus on individual differences and not also talk about the cultural, but I think there's a reason why that makes sense in a lot of ways, because when you look at how the ESTs often work with cultural differences, is you would base your treatment, basically you figure out the diagnosis, you figure out the cultural group, and you could figure out the right treatment that you should use and will be most effective with this client. But that doesn't allow for within group differences, it doesn't allow for those individual differences, all these different things. So there is, I think, some reason for this language, but within the discussion of it, certainly culture is an important factor within there. So evidence-based practice does allow for and encourage and even says it is necessary to be able to adapt one's approach to the individual client and the culture of the client. So in the original construction of evidence-based practice, it was not intended to support a particular approach to therapy. In other words, it was not intended to say that cognitive behavioral therapy is an evidence-based approach. Existential therapy is an evidence-based approach. When you hear someone using that type of language, that's really a different understanding of evidence-based practice and where it started. Now, of course, we can say that it is valid to have different definitions and understanding of what evidence-based practice is, but that does not fit with this original conception, and I think it's best for us to go back to some of these earlier conceptions. It was not designed to show the superiority of certain approaches to therapy or categorize some as evidence-based and some as not evidence-based. Instead, it could be said that a therapist with the basic competencies implementing a bona fide therapy and able to adapt her or his approach to the individual and cultural differences of a client is practicing consistent with evidence-based practice. It is about the therapist, not the therapy orientation. So therapists can practice consistent with evidence-based practice. A theoretical orientation is not in itself an evidence-based practice. I think that this is a crucial distinction that's important for us to advocate for, and those that are concerned about the narrowing of evidence-based practice, and there probably are some people that disagree with me about this and that are listening to this and that don't have a problem with the narrowing or even prefer or advocate for the narrowing. But for those that are concerned, I think this is one of the critical things. Is we need to be clear. Evidence-based practice is something a therapist does, not something that orientation is. Competencies refer to basic therapeutic skills that can be adapted consistent with the particular orientation. So a competency is not something that is going to be practiced the same by me as an existential humanistic therapist as it's going to be by a cognitive behavioral therapist or a dialectical behavioral therapist or a psychoanalytic therapist. One can practice with competency but do it differently, adapted to the particular approach. Bona fide therapy refers to well-developed therapy that has the essential ingredients that are really part of these common factors, such as a way to assess and describe problems. But this doesn't need to be a diagnosis that we talked about. It doesn't need to be a specific assessment instruments that identify a diagnosis or put labels to the problem. There could be a wide variety of ways to assess and describe problems that work between the therapist and client. There should be a cogent rationale for treatment. Again, this is one of those common factors that is important when there's a rationale for treatment that can help the client understand the path. That is something that often is an important factor in therapy working. But again, this can be adapted to the particular approach. It's not just one way of doing this. That's important. Adapting to individual differences recognizes the need to adapt to the particular client, including cultural aspects. When you do the same thing with every client, regardless of the individual differences, cultural differences, that is problematic. So the approach needs to be able to be adapted. If it is approach that is too rigid, that can interfere with the therapist practicing consistent with evidence-based practice. So if the therapy modality is one that is so rigid that doesn't allow for it to be adapted to a particular client, then that does not mean that the therapy orientation is not evidence-based, because no therapy orientation is evidence-based, but that approach to therapy provides certain barriers to practicing consistent with evidence-based practice. So given this, evidence-based practice can support and work with many different approaches to therapy in a variety of ways. It can help various approaches from therapy, ranging from CBT to psychoanalytic to humanistic and existential, to become more effective within their own framework. So evidence-based practice can be used by therapists across orientations to become better therapists. That is what evidence-based practice should be doing. It shouldn't be trying to say, my approach to therapy is better than your approach to therapy. It should be saying, I'm using this within my own context, within my own approach to help me become a better therapist consistent with the foundations of my approach to therapy. That's very different. One of the things that the common factors also shows is that in the research that believing in your therapy orientation, that having confidence in it is actually more predictive of successful outcomes than the therapy approach that you use. So it is believing in it is important. Having that foundation, being competent in your approach to therapy is important. When we try to just utilize different approaches to therapy, that often interferes with it because we may not always agree with those approaches as deeply, but we also have not had time to develop expertise. It takes a long time to develop expertise in a particular approach to therapy. Longer in some approaches than others. And so to try and do all these different approaches doesn't work. If we can have our foundation, be flexible and adapt and integrate within that foundation of our approach and use evidence-based practice within that to become more effective, that's where we're going to be able to use evidence-based practice to become a better therapist. And so evidence-based practice can be flexibly adapted and applied in different contexts with different approaches to therapy. Now, when we get to talking about multiculturalism, this is something that I think was often missed in some of the critiques that have come out of the empirically supported treatments. I was very concerned that in a lot of the critiques of the DSM-5 that came out, and I was part of the Society of Humanistic Psychology, was still part of the Society of Humanistic Psychology and was at that time, that developed the open letter of concern about the DSM that garnered thousands of signatures and endorsements from many different professional organizations. But one of the things that I felt was missing in that letter was that there was an addressing of the multicultural aspects of this. And that to me was very problematic because there are, I think, some important multicultural issues when we start talking about diagnosis, when we start talking about empirically supported treatments and evidence-based practice. The way that we engage multiculturalism around this, I think, is very important and something that needs to be thoroughly integrated. With multiculturalism, it represents different ways of knowing. Now, what has often happened within the field of psychology is that we've used our same way of knowing. We've privileged a particular way of knowing that we think of as psychological science, that is the right way of knowing. We've privileged it. Well, that right there has implications for multiculturalism. When we say there's one way to understand science, there's one way to understand evidence, as soon as we do that, we are making a value statement that is privileging certain ways of knowing, often privileging ways of knowing that come out of a Western European tradition, a white European tradition. Well, this has implications here when we do this. There's different understandings of what is evidence across different cultures. There's different conceptions of how to relate to and express emotions. This is one that I like to talk about. It's very personal to me in certain ways. I married a woman from a different culture. She's originally from the Bahamas, and I'm from the rural Midwest, German background. My background was not one of expressing much emotion. My wife's background is one of strongly expressing a lot of emotions. So our comfort around these were very different. And when we started dating and got married, this was something that we really had to look at and deal with, was these very different ways of viewing emotion. And what was my implicit understanding of healthy ways to express emotions was very different than my wife's ways of expressing emotion. And she's a psychologist also. And so we looked at this a lot and talked about this a lot. That what you see in psychology quite often is that we privilege certain ways of relating to and expressing our emotion that tend to be ones that are consistent with the dominant culture's way of viewing emotion. That has implications. When you look at treatment of anger management, for example, there are very different ways of viewing what is healthy anger and what could be considered a healthy expression of anger in a number of cultural contexts might not be seen as healthy in the dominant culture in the United States. And so that can lead to different diagnoses, to being pushed into different types of treatment to deal with anger and try and change, adapt to express the emotion consistent with what is comfortable for many people in our culture, instead of finding what is healthy for that individual and help them make informed decisions about the way they want to relate to and express their emotions. So this is, I think, a very significant issue. Seen similar things around grief and bereavement. In a couple of places I've worked, and I'm starting to see this again where I have a practice right now, it is very common following the death of a family member or close friend for women to quickly be offered some type of tranquilizer. It doesn't happen with men, but it does quite often with women in these areas. I'm sure it does happen to some degree with men, but there certainly seems to be a difference in the clients that I've worked with about the frequency of this. I've not done the research to assure that generalizes, but it certainly has been my experience in these situations. Well, personally, I have some concerns about using tranquilizers in response to grief just in general, but particularly around these differences, there seems to once again be a message behind this, that there is a right and wrong way to grieve. And by forcing that upon people, it often interferes with the process of grieving. So this is a real problem. Psychology needs to be able to honor different ways of relating to and expressing emotions, particularly cultural and individual differences around these. And then there are different conceptions of what would be positive psychological self in different cultures. And this, again, has not been taken into consideration quite often. Most research on therapy effectiveness outcomes for the client defines for the client what is the ideal of mental health. So this comes right back to that point that I just talked about. We've already have the conception of what the client should be seeking often when they come in, instead of working with the client to find what they would like for the outcome of therapy to be. This is problematic, and this is imposing a value system. While this may take culture into account to some degree, it still tends to define health in terms of the dominant culture. That's a problem. Now, from my cultural background, that often is something that I'm fairly comfortable with for myself. But that doesn't mean that it is what is the dominant cultural perspective is right for all clients. I think that is something that is often missed in here. And again, this has significant ethical implications, I think. The therapist, often without awareness, then imposes on clients. As an example, when you select an outcome measure, you've made a value statement. In selecting that outcome measure, it is saying something. It is also giving a message to a client. They may not know quite how to interpret it all the time, but when you give someone a depression inventory, that is making a value statement. It is influencing the therapy process by doing that. I'm not saying that should never be done, but we should be putting that into a context and thinking about this in particular situations. A couple of examples that I often will use with this, and these are examples that came out of clinical work and supervision but have been adapted so that it's not about any particular client, but rather generally in kind of a grouping of several different clients into a situation. Individual comes in angry referred for anger management by their boss because they've been angry at work. Been angry at work about the discrimination that they've been receiving. Referred for anger management. Well, this is an example of where we're often going with the cultural norms of society instead of looking at things in context. When you look at someone who has been experiencing discrimination at work and they're angry about it, well, there are different options that we may want to look at. One, the person may want to learn to relate to and work with their anger differently because they need their job. That's a valid choice that they may have. In other situations, they may want to work in therapy on finding different ways to talk about and express their anger to channel it towards making changes within that organization or society in how they understand anger. So they might use it in a very different way. But yet what is often assumed in therapy is that, well, we have to help the person control their anger. That's not necessarily the only option that should be there. Well, that is not the only option that should be there. We work with the clients to find this. Another example, this is something that was debated intensely at a place that I worked and looking at this issue about paranoia and whether you consider paranoia in all situations to be part of a psychotic symptom, even if it might have a cultural basis. So, when you look at a lot of what's happening in our society today and what's being talked about around the Black Lives Matter movement, and we're starting to have a lot more visibility to the experiences of a lot of Black individuals about what they've experienced with racism, discrimination, often particularly with police officers. Well, now this can bring about healthy paranoia. And so what we really debated there was whether this could be considered a psychotic symptom if it was a healthy response. And many people argued, well, yeah, the DSM is a descriptive tool. So if there is the paranoia, you don't look at the context, you just look at the symptom. That's problematic. It ends up creating certain types of labels that we place on people when we do this. So we always need to look within that cultural context and look at and find ways to describe this that works for us together. This is why I tend to prefer in a lot of situations not using the DSM, but using a descriptive language of the problem that the client and I can work together on that may not have the same values judgment that some of these other tools such as the DSM might bring with them. So for evidence-based practice to be truly multicultural, it must free clients from prescribed views of positive or negative mental health and work with clients to make this determination for themselves. We need to help clients recognize the possibilities. They may not realize when they come into therapy that there are different possibilities of the directions that we can work in treatment towards the outcomes that we are seeking. We must allow and empower clients to choose what is abnormal. And abnormal is maybe not the best word there, but what is problematic, what they want to change, and not make the decision for them. I want to shift a little bit and look at a very different context in looking at evidence-based practice, though I think there are some parallels, and look at existential humanistic psychology and evidence-based practice. This is something that I've been doing a number of presentations on and writing some articles on over the last several years. I don't see existential humanistic psychology and evidence-based practice to be necessarily conflicted or antagonistic to each other, although there are a number of people that do perceive those as not fitting together very well. EH therapy has long advocated for various competencies, although they've not used that language as mentioned earlier. And these were the foundations of therapy. These are quite consistent with the common factors of therapy, consistent enough that when the common factors literature came out, there was many within humanistic and existential humanistic psychology that were tempted to say, this proves we were right all along. Well, I don't think that's quite fair. That's not accurate. But it does provide some support for a lot of the things that existential humanistic and humanistic psychology have been talking about for quite some time. They also fit quite well with many of the areas identified in the expertise competency section of the report by the Evidence-Based Practice Task Force of APA. A lot of those parallel quite well, although how mainstream psychology might implement those might be a little different than how existential humanistic therapy will implement them. Again, there was a lot of consistency across the different areas. We'll talk a little bit more about that more specifically with a list of those in just a minute. The foundations of EH therapy has been an integrative approach by and large. Having various stances, as Kirk Schneider might talk about, or approaches or competencies, if we were to use the language that evidence-based practice would have as the foundation. And from the foundation, it's integrated. Now, I think this is one of the important aspects of it, is that there is this foundation. And Bruce Wampold had talked about existential humanistic therapy as possibly being an ideal foundation for all practice. Rooted in these stances, approaches, and competencies that existential humanistic therapy has talked about. Now, if we were to go through the specific areas then of evidence-based practice and look at research, well, there is a weakness on few outcome studies in EH therapy, particularly in the more quantitative or randomized clinical trials approach. However, there are case studies supporting its effectiveness. And there are many other strengths that support existential humanistic psychology. Many of the foundations of EH therapy have been shown to be important factors in effective therapy. Working with emotions, working with meaning, prioritizing the therapy relationship, including warmth, presence, empathy, genuineness. There's been research on a lot of the specific aspects or ingredients of existential humanistic therapy showing their effectiveness in an overall therapy approach. And that might be a better way of really looking at outcomes anyway than looking at it by a full orientation, to break down the different factors and look at what is contributing to it. And when we do that, existential humanistic therapy has a strong foundation, including looking at aspects of this in outcome studies. It has a strong foundation supporting it. And research can also include additional research outside of the outcome studies. And this, again, there's been a lot of support for many aspects of existential humanistic therapy through this. You can look at terror management theory, as well as an article that I wrote with several colleagues that was published in 2005 to get a little bit more into this. Thus, there's a strong research foundation for EH theory and therapy, including qualitative and quantitative research, despite lacking the specific outcome studies. So I've talked about this existential humanistic therapy as providing a model for evidence-based practice. Not in saying that existential humanistic therapy is a model evidence-based practice, because again, I don't think we should be talking about therapy approaches as evidence-based practice, but rather the therapist, looking at the therapist and whether they're practicing and consistent with evidence-based practice. But it's a model in how we can look at this differently. We can look at it by looking at the aspects of the therapy. We can look at it by looking at the aspects of the theory and using this research to really get a better understanding of what makes existential humanistic therapy work, and then emphasize that in our approach. So I think when we do this, there's a lot of support. And this is what we need therapists to be doing, is not just to have blind faith in their therapeutic orientation, but to look at the various things that they're doing and look at what is effective and what is not effective, and then be able to work to adapt these some. So existential humanistic psychology values different ways of knowing beyond the mainstream as well. It is not against traditional quantitative research, as often suggested, or it's not against randomized clinical trials. However, it does recognize and emphasize the limitations of these ways of knowing. And Dave Elkins has been one of the people who has really written quite impressively about this, that it's not that these are invalid ways of knowing, it's just that they have their limitations, like all approaches to research and all approaches to knowing. And EH psychology takes a more inclusive approach to ways of knowing, including valuing quantitative and qualitative research. When we look at expertise and competencies, this list below here on this slide is many of the competencies identified by the APA, Evidence-Based Practice and Psychology Task Force. Clinical experience is based on many things: assessment, diagnosis, and treatment planning. But again, As I've said many times, not necessarily DSM diagnosis. Clinical decision-making and monitoring progress. There should be a way consistent with the approach to therapy about how to do that. There may not be outcome measures, there may be other ways of doing that. Interpersonal competency, this has been a pillar of EH therapy. Self-reflection and self-awareness, again, a pillar of EH therapy. The appropriate use of evidence, engaging research. It doesn't have to, again, be just certain types of quantitative research, but engaging the research broadly to inform practice and understand what one is doing. Understanding individual and cultural differences. Utilizing appropriate resources as needed, such as consultation, supervision, and training. Having a cogent rationale for a treatment approach. There's nothing in here that stands in contradiction to EH practice, but I think EH psychology at the same time will push to broaden some of these in a way that is not inconsistent with evidence-based practice at all, including emphasizing what is learned through clinical experience, supervision, and training. Emphasize the experiential learning and training aspects, and the importance of emotional and relational awareness and insight. Again, these are all very consistent with the language talked about on the previous slide, but EH therapy emphasizes the importance of not reducing these to mere skills or techniques, rooting them in something broader than this. When looking at individual and cultural differences, historically I think this is existential humanistic psychology's biggest weakness. It has emphasized the individual difference quite well, but sometimes when focusing just on the individual difference, we become blinded to some of the cultural aspects of it. And this is where I think EH therapy has at times made some big mistakes. However, recently this has begun to change, and there is a greater engagement with the multicultural issues. I don't have time to go into that here, but there's an article that reference here that is one where you can go find out a little bit more about this. So now, I've got just a couple minutes yet here. I want to just wrap up a little bit, reconsidering evidence-based practice. So we are better able to meet the needs of diverse clientele with different backgrounds, beliefs, and values, and different desired therapy outcomes and views of positive mental health if we have different approaches available. I think we've too often made ourselves look bad in the field of psychology when we've debated over which approach is superior to which approach. It's the wrong question. Therapists are going to be the best therapists they can be when they choose not the best therapy modality as determined by science. That's the wrong question. Instead, by finding the therapy approach that is the best fit for them as a therapist. As I mentioned before, the therapist's belief in the approach, confidence in the approach, that contributes to successful outcomes in therapy. And some of the research suggests that that is a more important factor, contributes to more of the variance than what is done. Believing in what you do is more important than what you do, in other words, according to some of the research, and I tend to agree with this research. It fits with my experience as a therapist, it fits with my experience as a supervisor. So finding the approach that works for you is the more important question. And respecting the different approaches. No one can work with every client. And sometimes different therapy approaches are better for different clients, but it's not because they're more effective in treating depression, but because they're a better fit for the value of the client in the way of working. I live in a community that really emphasizes EMDR. I have no problem with EMDR. I was trained in it, largely just wanted to learn a little bit more about it, but it's not something that I incorporate in my practice, except in very rare circumstances. And I have a lot of clients that come to me, and one of their first questions is, you don't do those eye movement things or that tapping, do you? It's not the right fit for them. That's not what they want for therapy, and that's okay. It's not that EMDR is wrong or bad. It's worked quite well with a number of people. And that's a good thing. But we need to recognize that all of our approaches to therapy have limitations, and we need to help clients find the best fit for them and their values when working with a therapist and choosing what therapist to work with. So evidence-based practice better serves the field of psychotherapy and the consumers of psychotherapy, which should be our primary concern more than the field of psychotherapy. So evidence-based practice better serves the field and consumers by avoiding the debate about which approach is best and instead helping therapists become better therapists within the therapy orientation they practice. And I believe that evidence-based practice can do that if we keep it as a broad, inclusive definition. When it becomes narrow, it becomes problematic. We need to reconsider evidence then. It is vital for the field of psychology that we have a broad, inclusive understanding of what evidence is. When we reduce evidence by privileging certain ways of knowing, it has negative consequences. It negatively impacts the consumers of psychotherapy. We need the broad, inclusive understanding. Evidence-based practice should broaden considering what is evidence in the field of psychology, has broadened what we consider evidence in the field of psychology, but we are regressing to a narrower understanding again, and this is unfortunate and problematic. It is possible to build from the early evidence-based practice and psychology foundations to continue to expand our understanding of evidence and be more inclusive. Well, thank you very much. I hope that this was helpful. Again, I'm very disappointed I wasn't able to be at the conference in person. If there are comments, questions that you would like to have, please email me, and would love to hear some of your thoughts and be able to answer any questions that you have. Since I wasn't able to be there in person, not as ideal to do it through email, but hopefully that at least is an option if you do have some burning questions or something that you would like to discuss related. Thank you very much. Hope the conference has been a wonderful conference. I'm sure that it was. And once again, thanks to all of the organizers.